great. Henry. Great. We'll just get started in a few minutes here. Perfect. I do see Sarah on. Wonderful. Thank you all. All right, it is close to well, it's top of the hour over here. So good afternoon, everyone. My name is Gabriella Gonzalez. I'm part of the EMI advisors team and the Gravity Project as well. It is really a pleasure to be here with all of you. I do see the waiting room is popping up, so we'll give folks a few more minutes to get settled, make sure your audio is connected, and we're gonna get started. As you're coming in, if you don't mind saying hello via the chat, we welcome your name, your affiliation, and see who we have in the virtual room. As a friendly reminder, we are recording our session, and all materials will be posted on our Confluence site. We'll provide you with an overview of that today. And we want you to be mindful of your background noise. I know some of us are still working remotely, so just please be mindful of that as we get started. And yeah, I see Jenna. Perfect. Please continue to say hello. Tim, Marianne, Gary. Awesome. Okay, so it's 2 minutes past 2:30, so we'll go ahead and get started. I would like to welcome you all, and I went over some of our housekeeping items here, but given the large number of attendees, everyone has been muted upon entry, and we really encourage you to use the Zoom features that are available, such as the chat function. When you want to send a message, a question, a comment, please ensure that you send all chats to everyone so we don't miss your message. We also have a reaction button. If you would like to speak up, if you don't mind raising your virtual hand, that will be a great indicator for us to queue you up and make sure that we hear from you. And if there are any technical difficulties, do not hesitate to contact our wonderful analyst who's in the background supporting us. Demry, we have her email here. If there are any issues, we'll be very happy to help you out. And for some of you who may not be familiar, I'm Gabriella Gonzalez. I'm part of the Gravity Pilots project team. I'm the pilots lead. I have supported and managed the adoption of innovative data-driven transformation initiatives and collaboratives at the local, state, and federal levels. And it is a true honor to welcome you all to this community of pilots. Currently, I serve as project manager for a few interoperability initiatives, including the pilot's workstream, technical assistance to the administration for community living, and recently supporting the CDC on a social determinants of health, public health business case, and use case development project. As you can see here, we have all of our agenda for today. We want to welcome you, introduce the team, and then dive into our piloting approach, some tools that we have available for our pilot participants, and you will get to hear from three representatives of, from three pilots participants, representatives from Alliance Chicago, Ocean, the University of Texas at Austin, who are currently driving and supporting pilot initiatives. We'll wrap up with some questions from the audience, comments, and then we will close out the call. And for some of you who are very familiar with the Gravity Project, you know that we follow antitrust practices, and all participants have the responsibility to comply with state and federal antitrust laws. I won't go into the entire slide, but this is part of our standard practice, and we want to ensure that we ground everyone on that. On behalf of the entire Gravity Project pilots team, I would like to virtually welcome the entire team and announce them here with everyone. We have Evelyn as our senior advisor. I already introduced myself. We have Demry as our analyst, Himali as our terminology subject matter expert, Sarah DeSilvi as our director of terminology, Brett as our technical subject matter expert, Jim, also known as James, which I think it's a warm name that I call you Jim. That's the name that I met you with. Our Chief Informatics Consultant. We also have our wonderful in-kind support from AMA, Corey and Monique, and we are so grateful for everyone's contribution to this day, which is kicking off our work group. Since we are a large community, we would like to get to know you a little bit better and see who is the audience on the other side. We will go ahead and launch a poll to get a sense of who we have in the virtual room. If you don't mind selecting the type of stakeholder that best describes your affiliation, that will be wonderful. We'll keep it open for about 60 minutes or so. Part of just getting to know our audience. I see that we have about 67 members joined so far. And please continue to say hello in the chat. I saw a couple of familiar names, which is wonderful. And thank you, Damri, for the links. All right. About 64% of participants have responded. Okay, we're getting close to that 60-second poll. Wonderful. Okay, all right, about 76%. Oh, we're almost 80 now. Okay, I think we can go ahead. I'm going to go ahead and end the poll and share the results with everyone, so you're able to see who we have here in the virtual room. I'm going to try to assess quickly here the top percentage of responses. So about 20% of today's virtual room identify themselves as part of a research organization, which is wonderful. And I feel like there's a tie at 18%. We have a number of you who are joining us from the health IT vendor, health professionals, healthcare professionals, wonderful. Other IT systems, service providers from community-based. And for some of you that said other, please let us know where you're joining us from the chat. Some of you have already started introducing themselves, which is wonderful. And it really shows that Gravity Project brings a very holistic community into our work. And we're so grateful and thankful for all your support and continue engagement. Thank you all for answering the poll. I'm gonna go ahead and move us forward here. Great. And to set the ground, I'm gonna invite Sarah, if you don't mind, Sarah, walking us through our project scope. Thank you.
I am so happy to. So Gabby, thank you for introducing me. Many of you might know me. I am the Director of Terminology of the Gravity Project. I am the primary steward of our public meetings that happen during our terminology build sessions and IG build sessions. It is so good to see so many friends on the call. I see so many names and people that we've worked with over the last few years, and it's really exciting to be here as we move our deliverables into action in our pilot work stream. So it's my honor to kick off our Gravity Project scope. So the mission of the Gravity Project is to advance and promote equitable health and social care by leading the development and validation of consensus-driven interoperability standards for the social determinants of health. And this is a grounding, it's our pole star. We always try to start with definitions, and I have to admit that, of course, as a terminologist, this is something that means a lot to me. So as we work in the space of addressing social determinants of health, these are the terms that we use. You'll see them repeated throughout all of our work. Our pole star, our mission is always health equity. It's achieved when every person has the opportunity to attain his or her full health potential, and no one's disadvantaged from achieving this potential because of social position or other socially determined circumstances. The Gravity Project is doing a fair bit of work in kind of further defining what that means to work in this space. So social determinants of health are commonly known as the conditions in which people are born, grow, live, work, and age, and they're shaped by the distribution of money, power, and resources. The social determinants of health does a lot of work here. Social determinants of health are by design usually community level terms. Social determinants of health offer not only risks, we talk often about social risks and social needs, they offer both protective and risk factors, Protective factors are the characteristics or strengths of individuals, families, communities, or societies that act to mitigate risks and promote positive well-being and healthy development. I'm going to pause for a second here because you can see we have brackets, right? So in our work, social determinants of health is community level. Protective factors can also be community level. Our next two terms go to the person. So when we're building terminology and a person is identified as having food insecurity, this is where we start to talk about individual level data. Protective factors can, of course, be individual as well, hence the bracket on the right. So social risks are the adverse social conditions associated with poor health. Social needs arrive from the patient-centered principles because these are the social risks that are prioritized by the patient. These social factors that impact health that the patient themselves have stated need to be acted upon. So all this being said, what we know very clearly from vast amounts of literature is that health equity is advanced by addressing social determinants of health, such as access to safe and stable food, water, housing, and improving access and quality of care. And this is where the mission of Gravity comes in, really building the data and data standards to enable this goal. Next slide, please. Recently, the Health and Human Services put out a roadmap, strategic approach to addressing social determinants of health, where they acknowledge that addressing social determinants of health requires coordination across sectors. This is, of course, again, well known to Gravity, where we try to ensure we have not just clinical, payer, HIT voices, but really center the social care experts. What we want to state very clearly is that where we're working in this stream, right? So upstream causes are structural forces, policies, and then the bottom of the downstream are healthcare effects. We're working in that middle space of addressing social care and social needs. So this is coordination across both clinical and social care sectors to promote health equity and achieve holistic care. Next slide, please. Furthermore, this is from a Sdoh report that happened really at the origin story of Gravity. This is a Sdoh report that talked about the challenges in social determinants of health data exchange. Where Gravity grounds itself is not trying to boil the ocean. We know our swim lanes. We focus mostly on standardization of individual level social care data collection and storage, and then the data sharing between ecosystem parties. Again, you think about that middle area, coordination across health and social care sectors, and developing the data and data standards to enable that work. Next slide, please. I do want to note that I'm pinch hitting. These are slides that I know fairly well, but our dear Evelyn Gallego is out of office today, so I'm trying to do my best to fill her ever so large shoes. So this is the Gravity project scope. As the leader of the terminology division, what we do on the terminology side is develop data standards to represent and exchange these patient-level social determinants of health data documented across 4 clinical activities. And they're not just, I want to be careful about the word clinical, because we know very, very well that screening and assessment happen in the social care space as well. So as we look at that word clinical, just think about it with like quotes around it. So the activities are screening using standardized tools, assessment and diagnosis or problem statements, goal setting, and really, again, thinking about from that patient-centered perspective. These are patient-centered goals, and then treatments and interventions. And these happen across the clinical and social care ecosystem. We're either referring to care team members in our robust patient-centered care team, or referring out to community services, community experts, and community interventions. You can see on the right, so we've accomplished terminology build. Yes, and maybe someday outcomes. Yes, Ned. For anyone who's been on a public call, you know that I do try to respond to the chat as I'm going, just because it creates a pseudo seminar. It's the former professor in me. So we've addressed terminology for these 4 activities for 17 domains now in the Gravity project, which is a great testament. Some of our brand new ICD-10 language for our last domain, such as transportation insecurity from the fall of a year ago, come out just this month, October 2022. So it's a big month for us. The other half of us is testing and validating through our IG the standardized SDOH data for use in patient care, care coordination between health and human service sectors, population health management, public health, value-based payment, and clinical research. Again, our scope is wide. We're always playing with all these different use cases as we're building our terminology and building our IG, just so we make sure that we're not leaving different use cases and settings out of our vision. Next slide, please. So this is the Gravity conceptual framework and use cases. So it's really important to note, and there's a big star here, that Gravity is agnostic to the systems and tools used to collect, exchange, aggregate, and analyze social care data. So we build the standards. They can be implemented in any setting. They can implement it in like with any kind of role. So it's really just out there as a recipe to be used as you wish. So the first priority is to gather SDOH data in conjunction with the patient encounter. This includes everything from outcomes of problem statements or diagnoses to patient-centered goals. The next thing that involves, usually we're imagining this as a referral out from the clinical setting into the social care ecosystem, but we do know very clearly that sometimes in coordinated and integrated care settings, especially in FQHCs or community health centers, sometimes these interventions are happening in a co-located space. But that next use case is documenting and tracking social determinants of health related interventions to completion. So I've asked for this service, and then we're documenting that service to completion. So whether it be connecting a patient with SNAP, or setting up somebody with, non-emergency medical transportation, if they're transportation insecure and have a medical need. All of these needs are identified, the intervention is ordered, and then we're documenting that intervention is completed. And the last use case, and a really critical one we think about, especially population health. I just talked at a population health conference just on Tuesday. Is gathering and aggregating social determinants of health data for uses beyond the point of care. So if our primary member of our pilot group today is that research setting, this is taking all that patient level data and aggregating it up and anonymizing it so it's de-identified, and then using it for research purposes. I also put on my ACO hat here and imagine utilizing it for risk stratification and resource allocation. So all of these three use cases, again, gathering SDOH data with the patient, documenting SDOH related interventions to completion, and gathering and aggregating SDOH data for uses beyond point of care are three primary use cases that guide our work. Next slide, please. So these are our three work streams. So on the one, and there we have had this model for a long time. We're very, very glad to finally add that pilot testing and implementation element. So on the terminology side, as I've stated very clearly, we build terminology across those four activities for all of our 17 social risk domains. I just want to make a statement again, as we build social risk terminology, we're also building protective factor data, and we can talk about that more another time. So as it goes through the life cycle, the final product of the terminology division are value sets in the NLM Value Set Authority Center. These value sets are structured in a meta way by activities such as social determinants of health assessments, social determinants of health diagnoses, social determinants of health goals, and social determinants of health interventions. That aligns with US Core. But we also aggregate them and group them by domains, such as food insecurity, and then within all the different activities within the food insecurity subtypes. And so you have food insecurity assessments, diagnoses, patient-centered goals, and interventions. It is these value sets that forms the intersection and the nexus with our technical team. These value sets are referenced and supported by the FIRE ID, the SDOH Clinical Care FIRE ID, which we'll talk more about later. And these value sets are very critical in the implementation section that we're just beginning now. We're super excited. As we work on finishing some of the FIRE ID work I'll talk about in a second, here we are. So we're ready to test and validate that terminology, test and validate our FIRE ID as well. There's a lot to say in 10 minutes. So the Gravity Project timeline, our origin story starts in 2017 with really kind of a multi-stakeholder meeting in DC, trying to figure out what needed to happen to advance the dial on addressing social determinants of health. And we recognized that data standardization was a key one, filling gaps in data and standardizing existing data. So in 2018, University of California in San Francisco Social Intervention Research and Evaluation Network, or UCF Siren, contacted with EMI to kick off the Gravity Project. From here on, you can see everything you know. So in 2019, we launched. In 2020, we published our first draft of the FIRE AG. All along, we've been building social determinants of health data across those 4 activities for ongoing domains. And we're just getting set to finalize our final STU2, our second version of the Fire ID now. I do want to note that you'll see this on another slide as well, that this year we've covered 3 domains in the spring: medical cost burden, health insurance coverage status. Oh, she's going to the next slide, sorry. We've covered health literacy, health insurance coverage status, and medical cost burden. We had planned to kick off digital inequity, food access, and neighborhood safety. As many people in the Gravity ecosystem know, all new domains are on pause as we work on trying to find funding to fund those domains in full. We do have seed money for kicking off digital inequity, and we're looking for match just to finish that domain. To kick us off, we're just looking for $150,000. So if anybody has interest in supporting the kickoff of digital inequity with a matching grant for the seed $75,000, that would be fantastic. And then on the technical work stream, you can see that where we are right now in October is again that Fire ID STU2 publication, and this moment, the ever so exciting Pilots Affinity Workgroup kickoff. We have been waiting for this moment for so very long. We're really excited to hear from our pilot sites right now and to get ever so many more people in our Gravity Collective involved in piloting and testing our standards. Next slide, please. And all right, so this is the final slide. This is the Interopoly glide path. So we just want to make it very, very clear that as an HL7 Fire Accelerator project, we sit within the ecosystem of other Fire Accelerator projects. So the mission of a Fire Accelerator project is to develop and test encoded value sets for use in fire. And our current mission is to refine, test, and ballot this HL7 Fire SDOH Clinical Care Implementation Guide, STU2. And we have the slide on the right is really talking about how we sit in the context of other fire accelerators out there, such as the Karen Alliance or Codex or Da Vinci or the Fire Argonaut Project. Next slide, please. Whew. I think that's the end of my presentation. I'm now going to pass the mic off to Gabby until we come back to me to talk about a tool that we made to assist in any pilot site in identifying where they sit in the pilot 3-tiered approach.
Amazing. Thank you so much, Sarah, for jumping in and supporting. Unfortunately, Evelyn doesn't regret. She is traveling as we speak, and she's just extremely proud of the team. And thank you all for joining us. So I will do a little bit more of a deep dive into the work group that we are launching here today. So before we get there, I really want to thank all of us sponsors for their efforts. They have contributed towards helping us get this new Gravity Pilot work group off the ground. With ONC support, we're accelerating real-world testing of the Gravity terminology and technical standards, as well as supporting the publication of that HL7 Fire IG, as Sarah mentioned. So for those who may be new to the technical side, FIRE stands for the Fast Healthcare Interoperability Resources, short for FIRE, and they are an open standard for exchanging healthcare information electronically. FIRE describes data formats and elements known as resources and an application programming interface for exchanging electronic health records. Specifically, ONC is providing funding to 2 pilot sites, Ocean and Alliance of Chicago, as well as the UT Austin LEAP awardees. Who is one of the LEAP awardees. Without their support, we have not been able to be here today. We're just very grateful for their continued collaboration. ACL back in 2020 launched a social care referral challenge that was pursuing for the community to come together and propose and develop IT solutions to support healthcare systems and community-based organizations to partner and improve holistic health and social care for older adults and people with disabilities. The challenge itself has was composed of 4 phases, and the goal was to demonstrate the need for really demonstrate how seamless exchange of referrals can happen while optimizing individual social care data to ensure patients' needs are being met. IHE has supported our efforts by providing and funding to create a fire assessment guide that we're going to be showcasing and reviewing at our next work group meeting. We are so grateful for their support, and AARP has also supported the development and improvement of pilots education materials. We're leveraging the expertise of our Gravity Technical Advisory Committee, which some of you are part of and have really supported us to get here today. In terms of our goals, so the Affinity Pilots Work Group, we as a collective aim to establish this community to test and validate the Gravity Project standards. We will accelerate real-world testing and implementation of the Fire IG as mentioned, and it's really to create a forum where we engage community-based organizations in a standard-based exchange with clinical and social care systems. We want to demonstrate how clinical data can support upstream data used for population health, public health, quality improvement, and research. Some of you might be looking into the links that Deborah is sharing in the chat. This particular forum is a peer-to-peer learning forum where we want entities that are participating in maybe part of the testing or the full gamut from terminology and technical standards testing to come together and share, the lessons learned, challenges, seek partnerships, and being able to be part of this community where we're exchanging and accelerating the use of SDOH information across health and human services ecosystem while promoting individual privacy, safety, security, and accountability for patients' records. We do have 2 levels of participation. You can join as an observer if you are not sure whether you are able to pilot, have a team together to pilot. You're more than welcome to join as an observer where you can follow the progress, participate on calls, participate in discussion, but there's no commitment to testing the standards. If you are joining as a pilot participant, we do expect pilot participants to at a minimum, test 1 primary use case for a 6 to a 12-month period. Those use cases that Sarah reviewed are, our core use cases that we're referring to there. And we do want to note that interested entities must assess their terminology implementation as well as their fire adoption capabilities. We here, the entire team is here to support you and assist you through that self-assessment process and, be able to, if everything, checks out, you will be able to join us and present at our future meetings. So thank you so much, Denver, for sharing the links. We do encourage everyone to officially join the work group via the link that's on the chat right now. It is a listserv. If you haven't signed up, once you do, you will receive a calendar invite, and all of our materials are posted on our Confluence site for knowledge management purposes. And for those that are interested in participating as a pilot participant, we do have some systems roles for you to keep in mind. So, if you are part of a care coordination platform or part of a team that works with care coordination platforms, patient applications, referral recipients, and referral resources, that would be, applicable for you to join our pilots group. So again, these are listed on our Confluence site. I won't go into each one of them, but we'll work with you to assess your capabilities along the way. We have created, as mentioned, some educational materials to really support the understanding and application of the Gravity standards. We have a 3-tier testing approach that Sarah will go a little more in depth in a few minutes. We also, as mentioned, have developed a fire implementation readiness assessment, short for fire assessment, which is an Excel spreadsheet posted on our site. And I'm going to demo our site in just a few seconds here. We have, have a presentation on use cases for testing. We also have a Gravity, pilots, Affinity, Workgroup one-pager, if you want to encourage any of your community members to join us and listen and get aware of what's happening. That might be a good way to let them learn about us. And then, of course, for those pilot participants, we have a presentation template, and you will get to see that in action today with our 3 sites mentioned. So I will toggle here for just 1 second into our Confluence site. So this link should be right there in the chat. As you can see here, we have the systems role described. We also have a call out for to join the group. This will be the listserv. So when you sign up, there's a form just to collect your information. If we do ask you, what might be your level of testing, and part of today's meeting is to go over our pilot tier level self-assessment tool, and that will help you walk through that process. And then once you complete it, we'll receive this in the back end and add you to our listserv officially. From there, we have our active pilot partners who you will hear from today. We go into the use cases. We describe the materials. So this is actually the pilot tier level self-assessment tool that is meant to help you assess your capabilities, and you can download it from here. For some of you that might be new to Confluence, our fire assessment, our presentation template, our one-pager, and we'll feature all of our meetings. This meeting is being recorded as well, and the deck and the materials will be linked here. You'll see all of our meetings, and the materials within 2 business days will be published here for everyone's awareness. And at the bottom, we have our contact information, just so you're aware of the team that I just introduced today. So thank you. I know that's a lot of information. I just wanted to do a quick demo on where everything is located. You won't miss anything. We're here to support you along the way. And just to kind of recap on some of the steps, and I hope that I don't go into the first deck. Let's see. I'm so sorry about that. I'm gonna move quickly here. It's my first time using SharePoint to present, but I just wanted to make sure I did a demo on the Confluence. The next step was really to recap for participants to get engaged with us. We want you to confirm your capabilities, make sure that you identify the systems actors that you have or need to complete your pilot. We'll schedule you and your presentation so you can be part of this monthly forum on Thursdays to present on your goals of the pilot, and of course attend our meetings and stay current with updates. And you will, once you complete your implementation, we'll love to bring you back so we can share your lessons learned and do a pilot closeout presentation. I'll pause here and see if there are any questions before we dive into the tier level assessment. Okay, hearing none, I'm going to give the mic back to Sarah.
Hello, everybody. So I'm really happy to present something that some of you may remember. So those individuals who are on the technical advisory committee worked very closely with both the terminology and technical team on developing a tool for anyone in our community to find themselves within our pilot approach and our pilot initiative. So the Gravity Project has developed this 3-tiered pilot approach, and it really defines these incremental tiers for testing Gravity standards, and they're both standards of terminology and standards of tech. They build off of each other. So tier 1 is really just basically testing terminology standards and evaluating your infrastructure. Each of these are dependent upon the other. Well, really, actually, all of them are dependent upon tier 1. So if you're testing tier 1, you're using Gravity terminology standards and you're assessing your infrastructure. In order to do tier 2, which is exchanging the terminology in tier 1, You need to be, again, referencing the terminology in tier 1 and exchanging it with any content or transport standard. And this does not have to be the SDOH Fire ID, right? So the SDOH Fire ID is the focus of tier 3. But if you're using terminology in tier 1, and this is like me, like Sarah DeSilvi, a family nurse practitioner in rural Vermont, I use terminology in tier 1 every day. So I myself in my little FQHC, I could be testing tier 1. The moment I'm exchanging that terminology within, again, those gravity terminology value sets that are available on the Value Set Authority Center, through whatever exchange of content and transport standard that's available to me, whether it be CCDA, HL7V2, or direct, right? I can test in tier 2, right? So I can find myself using the new transportation insecurity ICD-10 code, exchanging it by a CCDA, HL7V2, or direct, and suddenly I'm able to be tier 2, right? There's a lot of real estate in tier 2. This includes things like registries, claims transport, again, CCDAs, like referrals. We think about the vast utilization. We had met with some pilot sites who were using Epic, and they wondered whether Care Everywhere would be appropriate, and it absolutely would be, right? So again, anytime you're exchanging tier 1 terminology within any content or transport standard that's not the Fire ID of the SDOH Clinical Care Fire Implementation Guide, you're in tier 2. And then tier 3, again, dependent on tier 1, again, in order to qualify for tier 3, you have to use the terminology standards that we have established within the terminology division. If you're exchanging them and testing the capacity of that amazing genius of the technical division, which is that SDOH Clinical Care Fire Implementation Guide, that is tier 3. So that's implementing the complete Gravity Fire ID data model. Again, you're utilizing those use cases, and you're importing or exporting SDOH data sets via the Fire ID and your current technology. So most of the current pilot sites are tier 3 testing. However, I really want to make sure that everyone sees themselves in any of the pilot opportunities. We did, for this purpose, develop a tier level self-assessment tool, right? Everyone knows who's been involved in Gravity that we are inclusive by design, right? So we try to meet everybody where they are and develop pathways and patterns that people can see themselves in, so we can all collectively make good work together, right? So if you were to go to the whole tier level self-assessment tool, you would see that we've developed 4 different tiers, right? The focus of the pilots is tier 2, tier 1, tier 2, tier 3, but we didn't want to leave out those folks who are on the pathway to testing. So we really have created examples. This is just kind of repeating the whole intent that we said on the previous slide. But again, in that tier 1, whether you're a community-based organization that has the capacity to assess things and exchange information with an ICD, or whether that would be tier 1, or if you're exchanging information with a Head Start from FQHC, right? That's all tier 1. So the purpose of tier 1 is, again, the social risk data, either screening, diagnoses, goals or interventions, documented in a simple method. Again, we're evaluating the structure and value of the data because terminology wants feedback, right? We want to know that we've made these terms that are useful. We want to know they're meeting your purpose. And so part of tier 1 testing is giving us feedback on the terms themselves, right? But we also want to make sure we understand the impact that collecting the information and the format will have compared to what you were doing prior, right? We recognize the burden of this work, we recognize the complexity of this work, and we want feedback on that too. So the next thing we're doing, again, is kind of a halfway point, again, between tier 1 and tier 3. You're using the gravity vetted terminology and value sets, and you're really just evaluating how those terminology sets are maintain consistency across exchange content and transport standards. And then tier 3, again, is evaluating the gravity vetted terminology using the SDOH Clinical Care Fire Implementation Guide. So if you were to use the tier level assessment tool, there's a set of questions and answers, right? There's a set of activities, like where my organization is screening for social needs using paper, right? That would be planning. Or it would be, my organization is identifying patient-centered goals with Gravity SNOMED CT, right? So that's tier 1. Or it'd be my organization is sharing information regarding diagnoses using CCDA or direct. That's tier 2. Or it's my organization and my system, right, is using Gravity terminology and testing the Sdoh Clinical Clarifier Implementation Guide through any of our different activities and any of our different use cases, and that would be tier 3. Again, the hope is if you get to the tool, and we vetted this tool with the TAC and we've showed it to different stakeholders, we really tried to make sure that it was as good as it possibly could be. If you use this tool, you should be able to find yourself on the path and also find a way to participate in this meeting, right? So we want people, anyone to see themselves in this affinity group. We want anyone to find themselves in that self-assessment tool. And we want to facilitate your engagement in this work wherever you may be. If you're planning, we will meet you. If you're tier 1, we will meet you. Same thing, tier 2 and tier 3. This is just an example of some of the terminology that can be exchanged with tier 1, right? So this is all Gravity Project Terminology Division deliverables. The encoding of the hunger vital sign is that first bucket. The development of food insecurity, SNOMED CT and ICD-10-CM is that diagnostic bucket. Again, these all align with those activities. So you have assessment in that purple box. You have diagnoses and problem statements in the teal box. You have patient-centered goals in that blue box. So this is again SNOMED CT. You have food security as the meta goal. And then an upcoming goal that's to be determined is feels food intake quantity is adequate. And then over here in the light blue, you have the intervention terminology. And this is primarily in SNOMED CT. So you have educations, provision, and referral to community health worker. Again, the term referral to community health worker is an intervention terminology. That activity of tracking the Sdoh, the intervention to completion is available through either tier 1 or tier 2, right? Or it could be a phone call and be tier 1. So either tier 2 or tier 3 if you're using content and transport standards, or you're using the Sdoh Clinical Care Fire IG, or if you're doing old-fashioned, Sarah DeSilly works in rural Vermont, the old phone call and fax. So I hope this is helpful. Again, the tool, we want feedback on the tool. So if you see the tool and you have ideas about how it can be improved, just let us know. But mostly we want to develop a way for everybody in the ecosystem, all of our friends, all of our stakeholders, all of our settings to see themselves in the work at hand, which is testing our standards, both terminology and technical, and making sure that it meets grassroots evaluation. So back to Gabby. Actually, I think, and also we're about to hear from our pilot sites. So any questions? That's a very brief overview of the tool. And again, you can find it on the Confluence.
Thank you, Sarah and team. It really took a village to develop the tool. I can attest to that. I think many of us can attest to that, really careful, not only, making sure that it's usable, but it translates well. So we will definitely love your questions. We know it's a lot of information to process. We are open to communicating via the chat. So if you have questions, concerns, comments, don't hesitate to chat them in. If you want to speak up, you can raise your virtual hand. And without further ado, so hopefully as you hear our upcoming pilot sites, things will start getting a little more into the tier approach that we are pushing, and we're hoping that more entities can join our efforts. It is a great honor to work alongside I call them our first cohort, our pioneers of tier 3 that really are setting a foundation for us to continue to build from. We are honored to support the ONC awardees. As mentioned, we have Ocean Alliance and University of Texas at Austin. And we also want to give the kudos to the ACL Phase 2 Social Care Referral Challenge teams. I'm not sure if everyone there is on the phone today, but closing the loop together in Southeast Michigan, Firefly, the Missouri Aging Services Data Collaborative, and Thrive Hub. As part of the challenge, they were asked to test our standards, and we are extremely grateful for everyone's work thus far. And you will hear from 3 pilot sites today, starting with Alliance in Chicago. And this is an outlined other presentation. You'll get to see their foundation and then really dive a little more into their workflow and success metrics. So without further ado, I would love to call upon Shannon, Alliance in Chicago, to help us get started.
Great. Thank you, Gabby, and thank you everyone on the Gravity Project. I am Shannon Pohl. I'm the Director of Informatics at Alliance Chicago, and I'm honored to present with you along with Nicole Padula, our project manager representing Alliance Chicago. We are super happy and honored to be presenting today. And thank you to funders, sponsors, industry experts, and stakeholders. If we could proceed to the next slide. We are honored to work with this pilot team representing those that are based at Alliance Chicago, as well as our pilot health center, Heartland Health Centers. So gratitude to the collective team for this pilot. If we go to the next slide. If you're not familiar with who we are, Alliance Chicago is a health center controlled network of community health centers. We represent and serve the needs of over 60 unique community health centers, many of them federally qualified health centers in the state of Illinois, as well as over 17 states. Our mission is to improve personal, community, and public health through innovative collaboration with our work focused in 3 core areas: healthcare collaboration, health IT, and health research and education. Go to the next slide. We felt the business drivers were super important and aligned with our strategic initiatives at Alliance Chicago for achieving health equity and improving overall health outcomes, not only for the patients that we serve in the safety net, and specifically addressing social determinants of health. Specifically for our business use case, we were thoughtful that when addressing social determinants of health, that there's a degree of care coordination and communication that can be served with this innovation through the Gravity Project for increased continuity of care for the patient, to lift burden in terms of the approaches of how this information is being communicated. And then overall, just coordinating between CBOs or community-based organizations and health centers. It takes a village in terms of serving the patient and making sure that their needs are met, especially in regards to social determinants of health. And we wanted to make sure that the needs of our health centers and community-based organizations were served in this project. So if we go to the next slide. So we are a tier 3 pilot participant. We'll go in a little bit to discuss what we're going to be concentrating on. Our pilot use cases are to be documenting social determinants of health data in conjunction with a patient encounter. We wanted to make sure that the pilot use case represents a real life clinical encounter that is happening today at our health centers. And then making sure that it's documenting and tracking social determinants of health related interventions to completion. The workflow that we're going to be piloting, as spoken about in the pilot scope, is testing a FHIR data exchange between Heartland Health Centers and a community-based organization that utilizes social determinants of health data. We are in the existing testing period until January 2023. Heartland Health Centers is our participating partner. They are a federally qualified health center based in the north side of Chicago and surrounding suburbs. They serve as a medical home for over 27,000 unique patients, and they are super innovative, especially in regards to how they're developing new care models for social determinant of health needs. And we are in the final stages of identifying who the partner community-based organization is, and we will certainly keep you posted as the pilot proceeds. So if we go to the next slide. So in terms of the system roles, so in working with Heartland Health Centers, they are already, you can see on the left-hand side, fulfilling the tier 1 system approaches now. They're capturing coded data, they're storing it, they're using it, and they're supporting internal intervention workflows. And we are a tier 3 pilot participant. We're going to be focusing on key workflows that they've voiced are important to this project. So definitely care coordination. They work a lot with community-based organizations in terms of identifying social determinants of health needs and barriers, and working with community-based organizations to help serve those needs in a holistic fashion. So definitely the care coordination platform is where we're concentrating on. And in that workflow, it's referral based. So as part of their standard clinical workflows, they're identifying where it's best to refer the patient according to their needs, according to where the patient's at, meeting the patient where they're at. So we want to make sure that this pilot is representing those key realistic workflows. We'll proceed to the next slide here. So the standards and technologies under consideration for our pilot effort, certainly we want to be focused on existing documentation workflows that they do now for SDOH. They do as part of their standard workflows, the prepare screening, which is a standard screening used across many of our health centers, and probably many people are on the phone are familiar with the NAC prepare screening. They utilize this now in their standardized clinical workflows. And they also use diagnosis codes and interventions as part of the overall SDOH assessment, screening, intervention, referral process. And then the exchange standard that we have chosen is fire observation. Just in reviewing this with the health center and overall and how it's documented right now, documenting as structured observations, we felt that this was the best one to try out to mimic their realistic workflows. Next slide. And I will turn it over to my colleague, Nicole.
Thanks, Shannon. So like Shannon mentioned, our FQHC partner is Heartland Health Centers, a longstanding partner of Alliance Chicago with many locations across Chicago, the north side and suburbs of Chicago. And they use Athena Practice as their EHR. And we will also be engaging a community-based organization that also serves the Chicagoland area with a broad array of integrated care services who works very closely with Heartland. Next slide, please. So just a little bit about our proposed pilot workflow. So while we work through the specifics with our partners, at a high level, the test exchange is going to focus on an existing patient workflow where social determinants of health data is gathered at Heartland Health Centers and communicated to the CBO. And then, as with all of our work at Alliance Chicago, we will ensure that the basic tenets of human-centered design are invoked in this project. Our work in the informatics department at Alliance Chicago goes through kind of that standard process of discovery, design, development, testing, and deployment. So really in that discovery stage where we're researching and having those workflow discovery discussions, design where we're prototyping and speccing out the solution that we're going to test, development where we are actually building the content based on the prototype, or in this case, building out that fire test exchange. Testing, all of our content goes through multiple stages of internal and external testing. And then finally, deployment, where we are putting all of that to the true test in a live patient environment to use in a real patient workflow, because we know that's the ultimate test. And this is really an iterative process, so sometimes we'll cycle through that, but something that we really try to have at the core of our work at Alliance. Next slide, please. So just a few logistics. So general timeline, we began conversations with Heartland earlier this summer, and we are currently working with both Heartland and the prospective CBO on workflow design and discovery. We'll have that fire test exchange of information complete by this coming January so that we can provide a report out to this group. And then we just wanted to call out some of the challenges that we may face here. First and foremost, I think everyone is well aware of the overwhelming burden our FQHCs and our community-based organizations are feeling right now, particularly serving as that safety net for this patient population. We know that resources are limited. They're oftentimes facing staffing shortages. It can be a challenge even for a very worthwhile initiative to identify those additional resources and hours needed. And then obviously some technical challenges that we may face. We know that there will be kind of a game of translation that's often an art and a science here to translate the fire implementation guide to our current systems. And then lastly, we are well aware of the challenges at the patient level and the stigma that makes it a challenge for the patient to share some SDOH information with their provider. Next slide, please. So how are we going to define success? Number one, that we'll be following our established solution architecture for how social determinants of health data will flow, and that the test exchange will stem from a patient-focused workflow. And then our key performance metrics, really completing the defined tasks during the established project timeframe, and obviously completing that test fire exchange in the established timeframe as well. And then if we go to our last slide, just a few resources that we'll be looking to guide the specific SDOH components of the exchange. The CDC has a great toolkit with resources on how to put SDOH into action. And then the NAC Prepare assessment tool, like Shannon mentioned, standardized SDOH screening tool that's highly used among our health centers. And finally, an article from the Journal of Ambulatory Care Management with some really great guidance on the process that several organizations follow to develop SDOH tools at their organizations. And that is the end of our slides, but thank you so much for your time. I know there's a Q&A later. We're also happy to answer any questions in the chat as well. Thank you.
Thank you, Shannon and Nicole, for a wonderful presentation. And we're so excited to see your updates in the future. Thank you so much. And I will call on Ned from Ocean, if you don't mind getting off mute, and I will make sure I spotlight you.
Not a bit. Can you hear me okay?
Yes, we can. Thank
Great.
you.
Thanks so much for having me. I'm so excited to be here to share some of the work that we've been doing on the pilot with all of you. So I'm Ned Moss, I'm the Director of Social and Community Health at Ocean. You can go to the next slide if you would. And I want to say that I'm representing a pilot team who's been working really hard to put all of this together, and some of whom I think are on the call. Danielle Myers, our project manager. I'm sort of pinch hitting here for her to present on our team's behalf, because she couldn't be with us, but I want to acknowledge the work that this fantastic team has done. Next slide. So a little bit about us. We are a nonprofit healthcare innovation network, and we have around 150 community health center organizations coast to coast on a single instance of our Epic EHR, but we also provide consulting and research and a number of clinical support services for those members, which include federally qualified health centers, community health centers, rural, and also critical access hospitals newly as of this year. The pilot members that we were intending to be testing with were going to be in California and Wisconsin. I think since this slide was developed, the Wisconsin group, unfortunately, the FQHC we're going to be piloting with there wasn't able to participate, so they made the decision to withdraw. So we are down to one pilot site and in Northern California. I'll talk a little bit more about them, I think, in a minute. Our aim is to use an existing social service resource locator platform that one of our members, the Alliance in California and several others around the country, use to connect to their patients with social services in their communities. And our aim was to leverage that platform to connect it and integrate it through the Gravity Fire IG, through our Ocean Epic instance, via the Compass Rose programs module, which is the social care module embedded in Epic, and to use that to provide members with closed loop referrals. And as part of that work, we're also going to be providing feedback and completing sort of gap analysis to where the IG sort of wasn't suitable between Epic and Find Help, and where workarounds were needed to sort of bridge that gap. Next slide. Great. So for us, primarily, we're always working to drive health equity. That is built in and baked into Ocean's DNA. And to that end, we really focus on data-driven solutions, especially during the pandemic, have worked to create a number of virtual health systems in place and put those in place for our members. Technology, clinical support services, and as I've mentioned, we have a fairly broad research portfolio and leverage some analytics and evaluation capability that we've developed over the years. Currently, the biggest issue was our members having to go outside the Epic system. We work with a number of social service resource locators, the two biggest being Find Help, which used to be Aunt Bertha, for those of you who are familiar, and Unite Us. And the feedback we got over and over from many members who are using one or the other of those is that there's a duplication of effort required to enter patient information into two systems, to leave the EHR, to make a referral or check on a referral through the SSRL, and then to have to go back to the EHR and update it. So the idea is to be able to make that a true closed loop electronic referral and to close gaps in that care management loop and to make it more tightly bidirectionally integrated. Next slide. So given that sort of puts us solidly into the tier 3 pilot participation status. So we're focused on use case 2, which has a tier 1 component of documenting and tracking SDOH interventions, but also again closes that loop electronically. So we will be up and running by the end of November with our participating partner, and have been working with Epic and FindHelp to create and implement this integration. And also I should say that I want to acknowledge Alliance Medical Center of Healdsburg, California. They are an OCHIN member who's been doing social care work, as many and most community health centers have been doing formally or informally for decades, but they've really focused on housing, which is a challenge in their area in northern Sonoma County. They have 5 locations providing medical, dental, and behavioral health in really the rural and underserved areas in northern Sonoma County. And we're very happy to be piloting this with them. Next slide. So again, I touched on that there's sort of a tier 1 component to some of the work that we've been doing for a while. So we've really been for a long time been very adamant and disciplined about creating structured data for social determinants of health and social needs as it's been screened for and entered into the EHR. So we've been working through those tier 1, what we're calling for gravity purposes, the tier 1 roles for a long time, and also to make that information really quickly available at the point of care. But as we sort of move into those tier 2, whoops, if you wouldn't mind going back, those tier 2 and tier 3 roles, thinking about closing that loop electronically, we're using the direct referral light component from the Fire IG, the Gravity Fire IG. For those of you who are familiar, probably overly familiar with those stick figure diagrams that are very charming. That's the section that we'll be referring to as the direct referral light. Next slide. We'll be focusing for now on food insecurity, housing instability, and transportation insecurity. And that particular member is using Prepare, although I'll note that given the breadth of our members, we have member community health centers in 46, actually I think now 47 states. And they use a variety of different tools. So while we don't want to limit our members to any one tool, we are starting off, since our pilot members using Prepare, with coding and mapping and using the Prepare tool to capture those needs. And again, using the Fire IG direct referral light workflow. Next slide. So this is just, again, a snapshot of our partners. And I would note once more that unfortunately North Lakes was not able to work with us on this pilot, but we are still pleased to be working with Alliance of California. Next slide. This is our version of that stick figure diagram. And as I mentioned, I want to sort of touch back on the notion that we'll be sort of providing a gap analysis, not to say that for every use case and every situation that these would be gaps, but that they would be gaps in the or challenges and barriers in the implementation between the OCHIN Epic EHR and our FindHelp social service resource locator partner. So we've sort of created a workflow that starts from the Epic user, goes to the CDO and back. So really an end-to-end referral, a true sort of tier 3 referral workflow. And so again, our aim is to be able to provide feedback where either alternative workarounds or other workflows or other workflow components needed to be added or changed in the IG. Next slide. So we will be testing through at the end of January 2023. Again, we're intending to have the first test sort of up and running by the end of November. We're kicking off with the pilot clinic at the end of this month. So next week, I believe, this week or next week. And we'll have the technical design, as I said, finished by the end of November. Really, the challenge that we've seen is, as I alluded to with the member who wasn't able to participate, just the resource availability on this end of the pandemic. You can imagine, and most of you probably understand very well the limited resource availability and the challenges that community health centers in particular have faced and are continuing to face. And then so just the generally the things we're trying to work through, the gaps in implementation steps for those pilot members, which would include in particular on our end a lot of technical work, including mapping for different codes and different needs. Next slide. So for our key performance metrics, what we're really looking to evaluate at the end of this will be, are we able to do end-to-end testing of the Gravity Fire IG from a member using Ocean Epic through to a community organization, a social service agency, a community service provider, and then back into the EHR. So once we have that up and running, we'd additionally like to get all of our other Ocean members who are using Find Help onto that functionality once it's sort of tested and vetted. And then we've called out Unite Us here. I mentioned we have members who use other methods or other platforms to exchange information with community service providers. And we'd like to work with them. Unite Us wasn't in a position where they were able to partner with us on this project, but our hope is that in the future they will be able to work with us on that, and that also the other means that our members have of connecting with community resources can be integrated in this way as well, using the Fire AG. And so we really, I think our overall aim, I would say, is to create a no wrong doors approach to being able to exchange this information with community organizations. Next slide. So that's it for us. Please feel free to reach out if you have further questions or would like to learn more about what we're doing. Thanks. I'll turn it back over to you, Gabriella.
Thank you so much, Ned and the team at Ocean for such a great job. And we appreciate keeping us posted on your team members' availability. I'm sorry to hear about Wisconsin. We'll make sure we update those slides. Thank you. And without further ado, we have our wonderful third site coming on to present, Aliel at UT Austin. If you don't mind opening up your mic, that'll be amazing. I'm going to spotlight you.
Yes. Thank you for having us. And we are very excited to be here sharing a little bit about our work. I'm the Director of Research and Innovation at the Dell Medical School. And I think we can go to the next slide. This is our team. We have a great team, and I would love to talk about each one of them, but we don't have a ton of time. But as you can see here, we have a mix of informaticists and technology leads, project management, and of course, very important to us is community engagement. Next slide, Gabriella. So we are part of the Health Informatics, Data Science, and Epidemiology Division in the Department of Population Health. Our goal is to use data and information systems to transform and enhance the way that people get and stay healthy. And we have a variety of projects going on, from blockchain to all the way to health information exchanges work and this work here as well of SDOH management. Our pilot is here in Austin, but we do want to make sure that our solutions are replicable, and so they're going to be tested also in New Orleans and in El Paso with some of our colleagues there. Next. Our pilot is part of our, ONC LEAP project. And we call the solution that we have been building FIRED-enabled social and health information platform, or FIRED-SHIP. And the reason that we do have that name is because we have been building a platform called SHIP for quite a few years now that's already integrated within the clinical sites of some of our partners that allow us to work alongside the EHR, giving the same look and feel, but it then have this integrated exchange of information between organizations. The pilot is focusing on testing the use case palette package from the Gravity project, as a clinical decision support tool, using a patient engagement technology, which in our case is a mobile and web app that was also built through ONC LEAP project, where we build a mobile technology that allows individuals to get their data from health information exchange and then share their data for different purposes. And one of those is going to be the pilot in this project. And that allows literally to comply, organizations to comply with the information blocking rule, giving patients access to their data, and the Cures Act. The partners that you see listed here is one of our FQHCs, local mental health authority, the Central Texas Food Bank, which serves 21 counties in Central Texas. EMI advisory support us, understanding there's so many standards that we are utilizing, focusing our work. Of course, ONC and AHIEs in both Austin, New Orleans, and El Paso. Next. So the drivers for us, one is the school's mission of equity, diversity, and inclusion is very important to us. It's part of our core. We are built and funded by our community to help our community, but at the same time, we focus on developing innovative and transformative solutions that can help anyone nationally. The other driver for us is to make sure that clinical and social data is available to our care teams in our community and also to patients, and be able to fully optimize the process of social referrals and helping our community to improve the quality of their health. Next. So we are tier 3 pilot as well. And what we will be doing is specifically is documenting the SDOH data during the patient during the encounter. With using the mobile technology that I mentioned, document and track what goes on until the completion of the referral, and of course gather and aggregate the data. And in our case here, we are academic organization, so we will analyze and see how we can improve the processes. So we do a bit of research as part of this project. Again, it's a LEAP project that started in September 2019 and then in August 2023. So we a little bit over halfway through the project, and for the most part of the project was a lot about engaging our communities, engaging our providers to understand exactly how the workflow would be best built. And now we are set to start the testing, real testing in real settings in November, all the way to February, where we hope to, recruit quite a few patients to provide us input. The last thing I'll say here is that our pilot is for SNAP referrals with the Central Texas Food Bank. So it's very focused to make sure that we solve that problem, which it's about 80% of all the referrals that the food bank gets in Central Texas. And next. We have been working on all these roles of capturing, coding, storing, and using coded data for some time for different projects. So as a tier 3, we use all the tools that we have to be able to coordinate, get the patient involved in the referral process, place the referrals, manage those referrals all the way to the end when we see the completion of the referral. And I'll get to that in a second. Next slide. So here, again, we are focused on just food insecurity to make sure that we address that point specifically. SNAP is one of the challenges. There are other ones that could be developed in the future. And you see here some of the terminologies that we are going to utilize. And I think we can go to the next slide, Gabriella. So again, our FQHC uses NextGen. Our partner, our mental health authority called Interopoly uses NetSmart. And both of them have SHIP, our social health information platform, already deployed that allows us to be able to do this communication in real time using these standards. Community-based organization is the food bank, and they use Salesforce. We also integrate with their workstations, and the patients will be using FiredUp, which is our patient engagement technology. Next. This is where I wanted to get to, is the details of how things work today, the workflow, and then how we're going to optimize this, or we hope to optimize it. The community health workers, you know, they meet with patients, right? And they are the ones that really enter the assessments today in the clinical settings. In whatever tool they're utilizing, like Find Help, or Unite Us, or they EHRs themselves. The patient don't get to see what the assessment look like in the end. The next step is the referrals are placed, but the patient also do not receive any notification or follow-up necessarily, unless if someone is tracking that very closely. The food bank then is going to get an email, you know, with details. They do not necessarily use the same platforms as the providers. So they're going to get an email with details. This person is interested and needs some help. They're going to reach out to patients by email or phone. The email may go in the junk mail, so the patients may not be really, you know, engaged. But eventually they'll get on a phone call and they'll have some screener questions to ask the patient details like, are you a U.S. citizen? Does anyone else in the family already has SNAP, you know, services? To make sure that they actually qualify before starting the process of the application. So the food bank, you know, follow-ups and schedule an appointment once they define that someone is eligible, and the individuals bring the documents necessary in the appointment, and they process the application and send that application to Medicaid. But at this point, the food bank doesn't have access to the needs assessment that was done in a clinical setting, so they have to reassess the patient because they do provide other services beyond SNAP referrals. And finally, the food bank doesn't have any details from Medicaid on what happens with the application. So we don't, unless they reach out to the patient directly and ask, hey, did you get a letter from Medicaid and were you approved or not? Nobody would know what would happen. So if you can go to the next slide, Gabriella. This next slide is going to show how we're solving this, right? So if the patient shows up in the clinic for our project, they ask to participate in our study. So they're being consented as a research project. They ask to download, fire it up, install them in their phone, install a plugin, which is part of FireShip to be able to allow this communication to happen. And once they do, the first thing that happens is they get the assessment of needs for that clinic in their mobile app. They answer those questions. Once they finish and submit, the community health worker in the clinic is going to get a pop-up in their computer workstation, basically saying the assessment was completed. Click here and you see the results. And if the SNAP needs are necessary, they're going to place a referral within the ecosystem that are sending those referrals to the food bank. We know the food bank in Central Texas have the ability to take all the referrals that we send, but we still wanted to make sure that for other use cases and other CBOs that cannot attend to all the referrals, that they should accept or not. So the food bank is going to accept when they get a referral, another pop-up is going to show up in their computer workstation, say you got a new referral. They click on it, they accept. And at that point, the patient is going to get the 6 eligibility query questions on their mobile device. And once they answer those questions, the food bank receives another pop-up saying, here are some answers. Is this person eligible or not? They review the answers. And if they are eligible, they check a box saying that this person can go to the next step. And 2 things happen at that point. The patient is able to take pictures and upload the documents to the ecosystem so the food bank can start reviewing the eligibility further. And second, they can pick a date and time that they would like to meet with the food bank, whether in person or remotely through a remote session. and if they need a translation or not. So a longer time visa is going to be created for them. But when they submit that selection, the food bank gets something entered in their calendar. The patient has a calendar now, invite on their phone, and we're making sure that they are going to actually meet to go over the application. Once they submit the application, the food bank now has access to the assessment that was done in the clinic, so they can help the patient further with all the needs that they have. And another thing we've done is, even though we don't have a communication with the Medicaid to find out what happened, we will remind the patients within 45, 60 days and ask them, do you receive a letter from Medicaid? If you have, can you take a picture and send it to us? So the food bank can assess if there is a need to follow up, set up another meeting, and help close the loop with those patients. It's important to note here that we can customize this so that the community health worker is getting notifications every time something is happening, but they can decide not to. But what they can do is go to a dashboard within FireChip and see all the referrals they have placed and where they stand, right? If folks are stuck on the eligibility questions, if they all submitted the applications already, or if they have their meeting coming up. So you could see real time, because of the Fire APIs, where everybody stands in the referral. And our hope is that we can understand where things are falling through the cracks. And that's going to be part of the project of the research. Are people getting stuck to the fact that they're not eligible at all? Or because the applications are not, they're not answer the phone, and we can get a hold of them. So more on that later on. Next. So this is our timeline. We're going live in November, sharing the code to New Orleans and El Paso in December. So they'll go live in January. And this is going to be with synthetic data. We could not necessarily recruit another clinical provider and patients in a different region. It just adds quite a bit. And we'll go into the analysis early next year to submit reports to ONC nationally. Next, please. I think this slide was supposed to be challenges, which to us was determining this end-to-end workflow. Does take quite a bit of work understanding from everyone, and coming up with a solution that does not necessarily exist at this point. The timeline to do all that, and also engage the communities and understand from their perspective what's going to work or not, is challenging, especially when you're designing a solution that a software need that you don't know what you're designing yet when you're still doing the discovery. And finally, recruiting the patients, we anticipate it's not going to be an easy task. We have been through that in many projects, but I think we'll be successful because we have a great set of partners in our community. Next. The success for us is that we're going to be able to access real time what is going on with the referrals and understand what is preventing them to be completed. That's very important. Second is that we are providing meaningful assistance to these families that need nutritional help in our community. Then that we have learned a pathway to design and develop and demonstrate these solutions, because this is one small use case. There are so many that we need to solve in terms of SDOH coordination. Finally, we want to transition what we build, and that's what we do for our projects, from research and evaluation to eventually become implemented in our real community. So that's the end goal for our project. And finally, maybe inform the community and the industry here on how to advance this challenge nationally. Next. These are some resources that I'll leave to you all. Thanks so much. It's been a pleasure.
Thank you so much, Eliel, as well as our other participants, Ocean and Alliance. I do have a question, and I think, Eliel, you kind of answered a little bit. And George is wondering, since he works with a governmental human service agency, he's wondering if any of the pilot partners have either investigated a partnership with governmental agencies to exchange data. It seems like definitely there's a lot of engagement with community base, and wondering, whether that interface with governmental agencies is next. And I believe, Eliel, you were just mentioning about your work with SNAP. I don't know if you want to clarify a little more there.
Yeah, I think the answer there is Yes and no. We are, as we now have more details of what we're going to be solving and how, that one of our goals is exactly to pursue that. I think, Gabriella, we know that we have been discussing about the challenges around weak referrals, which are very similar, but different in some ways, where kids get poked twice in clinical settings, and then at the week's office, we want to solve that and also optimize that process. So yes, I think it's coming, but we don't have those partnerships established yet because, to be honest, we need some results of the pilot first to be able to then advance to the next stage.
Absolutely, thank you. And I will just share a little more that, from all our sites, they are more or less a smaller scale. So, I think Texas, you might have the biggest one so far, but we'll see the results in upcoming months, and we'll definitely continue to advocate for those interfaces and relationships with our mental agencies. Thank you so much for the comment there. We are coming close to the top of the hour here. It has been a pleasure to hear from all of our pilot participants, everyone in the chat, introducing themselves and getting familiar with each other as we are building this new work group. In the next few minutes, I'm just going to walk through our schedule. So this is a monthly call. We are meeting on the fourth Thursday of the month for 90 minutes, starting at 2:30 Eastern time. So next week, in next month, on October 27, you will hear from additional pilot partners, and we also take a deeper dive into the use cases. You have our information. We are so excited to continue this dialogue and this affinity work group. We're here because of all of you, so I really encourage you to stay connected. If you haven't done so, please officially sign up, express your interest to join the work group via our Confluence page. And I'll just remind everyone that we will post the recording and the slide deck into our Confluence site. There's like a little page for it. You'll see our entire schedule, and we'll be posting our agendas and materials there. If you have any questions of concern or concerns, you're please welcome to reach to me and Demry. We are supporting the management and behind the scenes of this wonderful work group. And thank you again to our wonderful presenters, and thank you to the entire community for being part of the implementing national standards. A big kudos to everyone who was able to make it. And if you're always welcome to get a recording and reach out if you have any questions. Without further ado, I'll love it, Sarah. You want to say bye? I know you started with us saying hello and bye, but I just wanted to thank you, Sarah, for your leadership and support during our work group here. For some of you that are interested in sponsoring, we are seeking a sponsorship to support our work. Thank you, Demry, for sending the link there. You can also follow us on social media and LinkedIn and Twitter to stay tuned with events, opportunities, and more ways to get engaged. And that will wrap us up unless anyone has questions or comments before we go.
Very exciting work, friends. Just thank you so much for joining us. So excited to see the standards put into action.
Thank you. Thank you all. So we'll see you next month. Appreciate everyone's attendance, and thank you so much for being part of this new work group.
Gabby, sorry. Somebody's asking.
I have a quick comment to you. This is Janice Tufty and Sarah and everybody. I serve on the Gravity Executive Committee, but I was on the community for 2 years, and I presented at Putting Care at the Center, a value plenary for complex care and social needs, and I talked about the project. And also there was a SDOH track where there was 3 different organizations that presented their SDOH, interoperability and implementation, and they brought a few things forward to me about it. So I didn't mention it, but basically one comment was they wanted to have a standard just for screening, right? Which would be very hard, but I just wanted to put that forward to you. So I could send you the track too. So thank you.
Thank you. We'll look forward to continuing the conversation there. I think that's definitely very relevant, and trying to see how we can best support each other there.
Yeah, that's great. Thank you. Bye-bye.
Thank you. Take care. Have a good one.